I would request Shri Anil Mukim, Principal Secretary to the Government of Gujarat, Health and Family Welfare Department, to share his experiences on the topic today. Shri Mukim, please.
Honorable Shri J.P. Nadda ji, Honorable Cabinet Minister for Health, Government of India. Honorable Shri Nitin Bhai Patel, Honorable Cabinet Minister for Health, Government of Gujarat. Shri Atmaram Bhai Parmar, Chief Whip. Shri Lav Verma Sir, Secretary Health, Government of India. Dr. Alan Labrick, Director Global M Health Initiative, John Hopkins University. Dr. Nata Manabde, WHO Representative, Government of India. Mr. Louis, UNICEF Representative to India. Shri Pankaj Bhai Patel, CMD Zydus. Madam Sangeeta Reddy. Professor Pranab Kumar Datta, Head of Medical Science and Technology, IIT Kharagpur. Dignitaries, ladies and gentlemen. As we gather here today on splendid winter morning in Mahatma Mandir here in Gandhinagar, I cannot start without a quote from Albert Einstein, a great friend of the Mahatma, who said, "The problems that we face today cannot be solved by the same level of thinking which created them." In no other field is this more relevant today than in healthcare. Huge challenges are faced by the healthcare sector in the form of emerging diseases, rising costs, shortages of human resources, inequity in access to quality healthcare, and so on. We need a new level of thinking and effort to solve these problems by leveraging and enabling technology and innovation. Friends, over the years, Vibrant Gujarat has evolved into a platform for business as well as social transformation. We view health as a critical element in achieving happy, healthy, spirited, and peaceful society, without which productivity cannot be enhanced or sustained. So in this direction, I am happy to welcome you to this theme seminar on health for all. All of us are aware that the reach of government healthcare infrastructure is limited. This often pushes people to incur heavy out-of-pocket expenditure on health services. This situation, in part, is contributed by lower expenditure on healthcare, ranging from 1% of GDP to 3% of GDP, which is far lower than the global median of 5% and far lower of 8 to 10% in the developed nations. Further, only about 30% of the Indian population is protected with some kind of health insurance. Thus, there is still a considerable scope of improvement in quality, access, coverage, and affordability in healthcare sector. Against this scenario, I am very glad to inform you that we are implicitly seized of the situation, and there are many initiatives taken by Government of India as well as the state government. Our Honorable Prime Minister has launched the Mahatma Gandhi Swachh Bharat Abhiyan with full dedication in the mission mode. Similarly, Honorable Chief Minister Gujarat has started the toilet for every household in the mission mode to address this issue. We also now recognize that the focus has to be on comprehensive healthcare rather than on remedy of a medical situation. This includes community health and hygiene, promotion, exercise, proper diet, and a healthy lifestyle. Attention to mental health and stress, and belief in the approach that healthcare leads contributes significantly to peace and happiness. In Gujarat, we have established a vast network of more than 7,000 sub-centers, 1,200 primary health centers, 320 community health centers, 55 district and sub-district hospitals, 19 medical colleges, 3 super specialty facilities across the state. We have been able to leverage this network considerably. Our maternal and infant mortality rate has come down as per the MDG targets. Sex ratio has improved from nearly 837 in 2001 to 905 in 2011. Budget allocation has substantially improved too. In the year 2014-15, our planned budget in this health sector was increased by more than 35 to 40%. Our E-Mamta, Nikshay, Ma Mukhyamantri Amritam Yojana, which includes cashless hospitalization for catastrophic diseases for BPL families for benefit up to rupees 2 lakh per family on floater basis. Ability Gujarat, Gujarat Hospital Management Information Systems, and GVK EMRI 108 are some of our initiatives which we are indeed proud of. In the end, I would like to emphasize on few areas we can jointly work on. First, we need to maximize the use of technology in addressing these challenges. We had a very, very comprehensive and a fantastic inaugural session. I'm very, very thankful to Union Minister and our Minister for their very comprehensive and a fruitful opening remarks. The focus so far in health was in improving the organizational structure, deployment, or capacity building. In order to make quantum leaps, we have to leverage technology. The concepts of e-health and m-health are also taking center stage, and they could be very relevant in our country. I am glad that we have a very, very distinguished panel of speakers on the subject. We also look forward to innovations from equipment companies, pharma manufacturers, to bring about improvement in diagnostics and treatment, to increase in access to provide quality healthcare at lower cost. Finally, we in government are acutely aware that technology and innovations cannot be implemented without supporting enablers in terms of policy, institutional, and viability support. That is why we have included the focus on enablement in our theme for today's seminar. We are once again thankful to all who have come from near and far, particularly the speakers. We are also extremely grateful to the Government of India for their support. In fact, as Honorable Minister also announced, Government of India has published a draft health policy for review just before a few days. Sir, we are very minutely going through each and every provisions of the policy, and by 20th of February, state government would be sending our detailed comments. We are planning to share the output deliberations of this seminar with Government of India as input for finalization of the policy. Let us all work together to translate into reality this vision of accessible, affordable, and equitable healthcare for all. Thank you and all the best.
Thank you, sir. We would now be having a joint presentation by Mr. Louis Georges Arsenal, Country Head UNICEF, and Dr. Sharad Sapra, Director and Principal Advisor, Global Innovation Centers, UNICEF. Both of them will be presenting the UNICEF's experience, and Mr. Louis George Arsenal is the representative for India for UNICEF and responsible for the overall coordination, development, formulation and management of UNICEF country program and cooperation. And he has a long track record of serving UNICEF at various locations and has distinguished himself in working for UNICEF. And he shares his presentation with Dr. Sharad Sapra, who has a career spanning more than 30 years with UNICEF and now heads the Innovation Center based in Nairobi. And we look forward to the presentations by both of these two gentlemen. Would you please take it from here? Thank you.
Mr. G.P. Nadda, Honorable Minister of Health, Government of India. Mr. Nitinbhai Patel, Honorable Minister, Government of Gujarat. Also, Mr. Love Verma, Secretary of Health, Ministry of Welfare, Government of India. Dr. Nata, WHO representative and colleague. And Mr. I think Matam Parna, who is MP from Gujarat, is still here with us, yeah? Mr. Anil Mukim, Principal Secretary, Health and Gujarat as well. And also Mr. G.P. Gupta, Secretary, Communication, Health and Welfare. So I'm very, very, very pleased to be here today. In fact, I have been in India just over 2 years, and this is the first time I'm attending the Vibrant Gujarat. And what an event, very, very impressive since yesterday, what we have seen coming together. And in fact, the world is on Gujarat today, and we are also looking forward to the discussion on how this is going to be expanding in many ways throughout the country. And I'm also grateful to the opportunity to be able to to contribute to this discussion this morning on the health sector and health for all. I just want to say a few things about an important aspect of our work, which is it's called the Convention on the Rights for the Children. It is the most ratified convention worldwide, and 2014 was the year which we celebrated 25 years of CRC implementation throughout the world. And it is an important aspect. It is important because India, as all countries in the world, have abided to this convention. And this is a very good opportunity to discuss the achievement over the last quarter century on child rights globally, but also it's a very good opportunity to look at some of the bottlenecks, some of the challenges that remains for the next few years, as the Secretary General mentioned yesterday, in terms of moving the agenda forward for the next 3-4 years, 5 years, but also beyond that for the next 15 years. And for us, it is critical also to look at what is actually the right to health in terms of making equal access. And I mentioned that because it's been mentioned a lot this morning already. Equal access to basic rights to life, survival, and development. As I mentioned, this is also an opportunity, the celebration, to look at some of the challenges that we are facing. And obviously, if we look at one way to overcome challenges and the bottleneck that some people have mentioned this morning, we are really looking at a different angle, which we call in our discussion internally and also with many partners, innovation for equity. And in fact, we've been busy over the last several years looking at, the last couple of years, should I say, looking at many throughout the world, and I think my colleague Sharad is very much involved in this globally right now, looking at best example and good practices over the world that can really scale up, bring things, innovation at scale to increase results for children in a reasonably short period of time. This is what we have been focusing over the last couple of years. So this conclave and this session on Health for All, leveraging technology, innovation, and enabling is very, very relevant and exciting. So what I will do is I will mention to you, I will just speak a little bit on the innovation for equity from a health perspective, and my colleague and friend Sharad will then expand on the global experience that we have had over the last several years and where we are going with this. In terms of contextualizing the conversation, I just want to mention a few. I don't want to bore you with a lot of figures, but I think it's important to contextualize the conversation here. Every year, 130 million children are born across the world. But, and then we know, that 6 million children will not reach the age of their 5th birthday every year as well. And about half of under 5 deaths occurs in only 5 countries. This is interesting. And these countries are India, Nigeria, Pakistan, Democratic Republic of Congo, and China. The good news is that progress, and I think this was mentioned by Love Verna and a few others, that there's been good progress globally. The number of under 5 deaths worldwide has declined by nearly half from 1990 to 2013. There is a but, and this is also will be linked to the India conversation, is that the decline of neonatal mortality has been okay. The decline has been, in fact, much slower than the under-5 mortality, and as a result, the contribution of neonatal death to under-5 mortality has increased from 37 to 44% from 1990 to 2013. So we can come back to this, but this is a very, very important point to be made. And when we look at India, India has a large population. I think everybody, this is a fact. And in fact, India accounts for 20% of total childbirth every year. Obviously, it contributes to the world's population. But at the same time, 21% of under 5 deaths of the world is occurring in India. And also more than 25% of global newborn deaths are occurring in India because of the sheer size of the country. Though India has the highest burden of under 5 deaths, it has also shown, and I think it was mentioned again this morning, the faster decline or in under-5 mortality as compared to the world, because in fact, globally under-5 mortality has reduced by 49%, and India achieved a 61% reduction from 1990 to 2013. So this is something quite commendable. And there is always a but, and the but is what I mentioned earlier, is neonatal death. Neonatal death accounts for 57% of under-5 mortality in India, which is much higher than the global average of 44%. So there is an issue there that needs much attention. And in fact, we do know why, and we know what the interventions are, and this is what I'm going to be focusing on. If we look at neonatal mortality, it's about prematurity and low birth weight. It's about birth-related complications and infection, which accounts to 80% of these born deaths. So very specific intervention, very specific areas are very clear. And we know also that most of the deaths are preventable with scale-up of simple intervention starting from conception to antenatal care, time around birth, and also postnatal care. We need innovation, and I think it's been mentioned this morning that there are many already happening, that will be able to us to address inequities, prioritization the most vulnerable, and also reaching the unreached, and also, as Dr. Nata was saying this morning, accelerating coverage with quality intervention, which is something that is very, very much critical. So let me share with you one example. I will only mention one example where we have been working with government of India over the last several years, starting at very small pilot and where we are right now today, a few years later. In Madhya Pradesh, which was the state with the highest neonatal mortality in the country, we have been supporting the government for the last several years in setting up what we call Special Newborn Care Unit, or better known as SNCUs, for care of small and sick babies with a real-time online monitoring. The issues I was referring to in terms of the causes of neonatal mortality, a lot of them are being addressed through the SNCUs. From this initial pilot in 2 districts only, in 2008, as we speak now, this has been scaled up throughout Madhya Pradesh, Rajasthan, and Andhra Pradesh, throughout these states, and we have been able to the government has been able to reach universal coverage at district level in these states, and this is being scaled up also in other states. It's also important to know that this is linked with stabilization unit at block level and home visit by ASHAs, which was mentioned by the minister and others, the community workers in the community to follow up and care. These state-of-the-art unit are an example where need-based innovation linking community, as Dr. Nata mentioned also, to health systems, resulting in sustainable reduction of neonatal mortality. In addition, with support through the National Health Mission in developing a real-time monitoring and tracking system for SNCUs, which in fact generate real-time information of more than 250 parameters, helping program managers with much needed evidence for guiding policy, investment, and actions for improved quality of newborn care. And I think I just want to end this in this example. The real-time monitoring systems has now been taken up by the government of India and is being scaled up nationwide and is being rolled out as we speak right now in 8 states, covering 45% of SNCOs of the country, with all SNCOs to be covered by the end of 2015. Currently, more than 400,000 newborn are registered in the new database with information available on a click of a button, making it the biggest database of small and sick newborn globally. And in fact, it is being discussed globally as a best practice that can be implemented elsewhere in the world. So let me conclude by, this is a very good example of something that can be brought to scale from one state nationwide and at a relatively short period of time in a matter of a few years. With our extended field experience we have seen, we are present in 13 states, we have seen that, as was mentioned earlier also, that many innovations are taking place right now, implemented by state government, corporate sector, and so forth, civil society. And what we are looking at right now, and I would like to end by a bit very much referring to what Secretary of Burma mentioned this morning. In fact, there are many of these initiatives which are small in nature, and some of them are being scaled up, but perhaps what we should be spending time, and I want to leave you with this thought, is that we should be looking at taking stock of all these hundreds of initiatives and see which one we can work together to bring to scale nationwide. So I'm leaving you with this thought. This is just thought for food, and thank you very much for this opportunity.
Speak when more than half of the points that you want to make have been made by the Honorable Union Minister of Health and then the Secretary of Health. So now I'm trying to juggle out my speech. So that, but thank you for having me here. And I'm not going to go into all the background and all, but we started working on a Global Innovation Center. The idea of that was, how do we actually take experiences from one part of the world to the other? And as has been said before, that the issues that are of importance in the South perhaps don't even have a relevance in the North. And so it's difficult to, and you cannot practically bring the North models into the South. And therefore, South-South models are the way to go, because the challenges that we face are very, very different from the challenges that others think we face. Our focus, therefore, has been on frugal innovations and focusing on one important aspect, and that is, how do you move information quickly from the place where it is generated to the place where the action has to be taken? And moving away from what happened in based information systems. Yes.
ગુજરાત રાજ્યના મુખ્યમંત્રી શ્રીમતી આનંદીબેન પટેલ અત્રે ઉપસ્થિત થયા છે. સરહદે આવકારીએ છે.
We just halt the proceedings for a couple of minutes while the Honorable Chief Minister is here. We are happy to announce that on the occasion of Vibrant Gujarat Global Summit 2015, the Health and Family Welfare Department has entered into 11 memoranda of understandings, out of which 6 are healthcare related memoranda of understanding and 5 are pharmaceutical related memoranda of understanding. I would just announce the organizations who have entered into the member of understanding. I would request their representatives and the officers from the government of Gujarat, their counterparts who have signed the memoranda of understanding, to come on the dais. Achi Hospital Private Limited, Healthcare Global Enterprise Limited, Wipro GE Healthcare, Param Group of Companies, Shankaracharya Healthcare Private Limited, Gujarat Cancer Society. From the pharmaceuticalists, Messrs. Faber Pharma, Media Pharmaceuticals International Private Limited, Messrs. Liva Pharmaceuticals Limited, Messrs. Torrent Pharmaceuticals Limited, and Messrs. UL Engineering, United States of America. And the counterparts from the government of Gujarat, please.
નામ બોલો.
Okay, I'll just repeat the names again. Is okay, Mrs. Fabo Pharma, Mrs. BDR Pharmaceuticals International Private Limited. Okay. Okay.
તમે સાઈડ પર કરો ને દેખાય. વિઝ્યુઅલાઇઝ થાય ને.
Okay. Mrs. BDR Pharmaceuticals International Private Limited.
Give them big applauses. Here's the memorandum of understanding.
Mrs. Liva Pharmaceuticals Limited.
Mrs. Media Pharmaceuticals International Private Limited. Mrs. UL Engineering USA. Mrs. Torrent Pharmaceuticals Limited. Now, memorandum with the company for healthcare MOU, Achi Hospital Private Limited. Healthcare Global Enterprises Limited. Then Wipro G Healthcare. SCG Healthcare Global Enterprises. Wipro G Healthcare. Param Group of Companies. Shankaracharya Healthcare Private Limited. Gujarat Cancer Society. Now we request Gujarat Cancer Society.
We start back with our plenary session.
Thank you. Thank you, all of you. ભાવેશભાઈ એક સ્પીચ ડિલિવર કરવાના છે કે શું છે કશું કશું ખબર નથી ફર્ધર કોઈ ઇન્સ્ટ્રક્શન નથી આભાર પરમ આદરણીય મુખ્યમંત્રી ગુજરાત રાજ્ય શ્રીમતી આનંદીબેન પટેલ.
We request the speakers of the plenary sessions to please resume their places, and we would resume the plenary session. That's it. I request Dr. Shahid Sapra to resume his presentation.
Okay. So as I was saying, I get to speak twice now. What I was talking about was that we focused on South-South, but on the single most frugal innovation, which was how do you move information from the place where the information is collected at the lowest level and the place where the action has to be taken. And move away from the normal system of what happened information, where once a month the information is collected and said, okay, last month 500 people died and 10 had this and 20 had that. Well, that's nice to make a presentation and keep a historical record, but it doesn't really help the people who are actually suffering when this thing is happening. So move away from what happened to what is happening system so that you get real-time information of what's happening now, so that the person who needs to take the action can actually take action. And then we have scores of information management systems, systems that are very complicated that actually manage information. Now, we don't need to manage information. What we need is information for management systems, where basically, what are the 4 or 5 critical pieces of information that you require to actually take a management decision? So, what are the diseases that are happening in the village? Is the drug there? Is the doctor present? Are the health workers there? These are the 4 or 5 things, if you get in real time, you can actually do something about it. But today's health information system, we collect about 150 data bits from every area. Who is going to look at those 150 pieces of information except making a presentation in a conference? And the health worker ends up spending 60% of her or his time actually collecting information instead of doing the health work for which they have been recruited. And collecting information that no one reads, no one analyzes, no one gives them a feedback, and which is of very little value to them. And we know that in any system, when you collect information that is not of value for you and cannot be acted upon by you, that system fails. And that's why the best of the technologically advanced health information systems have reporting rates of 15%, 20%, 30%. And the health workers actually have no clue why they are collecting information, for what, and what are they supposed to do with it. So the third thing that we focused on, and that is technology, is only 10%. I mean, don't start with a solution by taking a technology and say how we can apply it, but actually start with a real case and then develop user-centered technology that actually sitting with the worker, actually finding out what is it that's going to help them. And we came up with about 20 odd things. I'll talk about 3 or 4. Actually, one of them is very similar to eMamta or eKilkari that you have. All these systems that we have developed are actually open source, which means no proprietary, no licensing. You don't even have to ask us. You can go to GitHub, download the whole code, develop the application yourself, put your logo, use it, more power to you. The idea being that if investment has been made once, why should everyone else then have to make that investment? So the 1,000-day monitoring system, as we call it, which is what like Kilkari or e-Mamta here, basically does all the same things. We also have something called Rapid Pro, because what we realized was that it's very difficult for a medical person to try to explain to an IT person, and for an IT person to actually understand what the medical person is saying and develop a system. So most of the time it ends up being an IT system that has to be deployed by a medical person, and not a system that actually is originating from the medical person. So we developed something called Rapid Pro, which actually does not require a single word of coding. You have to, any language that you know for which there is a web font. So if Gujarati has a web font, you can actually develop the application yourself by using the logic. Decision tree, yes, no, other kind of decision tree, which you use in making diagnosis of many health conditions in any case. And once you are happy with that, you actually put, if you have an Android phone, put your Android phone number, your phone becomes a server, you can test it with your friends. If you are happy, you can launch it on the server. The only time you need an IT person is when you have to decide what kind of analytics you want to put, or a dashboard or website you want to put. But everything else is designed by the person and the user themselves. On birth registration, we have developed mobile birth registration systems, where essentially what you do, and this is all on dumb phone, no tablets, no smartphone, no high-end technology, on a simple Nokia $10 phone, you can actually, that only does SMS and voice. All these systems work on that. Basically on birth registration, there is a notifier, could be either the community or anyone assigned by the government as a notifier, could be the health worker. They notify this birth has taken place using a simple SMS. Automatically the SMS goes to the verifier, who is usually a birth registrar person or a designated person in the health ministry. That person verifies that the birth has happened, says confirmed, it goes to the Registrar General's office, and the birth certificate is issued. And the birth certificate comes as a code, like you do cash transfer or something. And then you can go on any website, put that number in, and your birth certificate is there. Instant. I mean, in Nigeria, they did 130 million birth certificates, I think, in 1 year. In Uganda, the birth registration rates went up by 35% in 1 year using this system. And there are many other countries that are now using it. Again, it's open source. The way we do it is using USSD, which is something that you use to top up your money in the phone. Because it's doing financial transactions, it's a very secure system. So again, technology is available. It's just how do you apply that in your health system. What we also found was that it's extremely important to actually have access to information for general public on various programs. So you can send it by SMS, but there is a limitation of how much information you can send on an SMS. It's 160 characters. But we built systems which use IVR, which is the voice-based system. Like you go to a bank, you call, and they say for menu 1, for this, press 1, press 2. Because voice has no limitation on how much information you can provide. So basically what we do is you put a query, select from the menu, and then the computer actually reads out using text-to-speech all the content of information that you want. We also have digital kiosks, which were awarded by Time Magazine as one of the 50 best inventions of 2011. Run on solar power, very hard build. All designs are available open, which means you don't have, there is no proprietary. You can take any social enterprise locally in Gujarat or anywhere, can take it. All the assembly instructions, drawings, specifications are there. You can put it together, and then you can deploy it. You can also create jobs, because what we did, for instance, in Africa, we partnered with banks and with telecom companies. So the young, educated person, unemployed, actually gets a job managing that kiosk. The banks can do their banking on that, the cash transfer system. The telephone companies can actually run their programs over there, and there is a part of information that's available free to public and is free access. The main, then for drugs, I think you have a very good program on drugs also. What we have, in addition to what you have, is something called M pedigree, which is all paid by pharmaceutical industry, because no one is more interested in making sure that only genuine drugs are sold in the market than the pharmaceutical industry itself. So what they do is they actually print a small area like a scratch card. So anyone who buys the drug can scratch it, SMS that to that code, and immediately they will know whether this is a genuine drug or not and whether it is within the date expiry period or not. So that way you make sure that genuine drugs are being sold, no cost to the user, no cost to the government, all paid by pharmaceutical industry. What is key in all this is partnership and collaboration. And what is extremely important is that the Vibrant Gujarat is actually bringing in everything for partnership and collaboration. So now, just for a moment, I would step out of my UNICEF thing and be an Indian, which I am. We sent a spacecraft to Mars, right? On 1/10 the cost of the rest of the world. We're getting pictures from there, we're getting audio from there, and all the information from there. And so it's difficult for me to accept that we can't get information from a remote part of India, in India, while we can get it from Mars. I mean, how is that possible? So we have the technology, we have the brains, we have the infrastructure to do it, and my question is, why not? So there needs to be some kind of introspection and saying, I mean, it's nice that we are getting information from Mars, but maybe we should get it from one of the villages as well. The second thing is, we really have a graveyard of very successful innovations which never went to scale. Everyone is doing something small here, something small there. We are publishing papers, we are reporting in conferences. Why is it that if we have all this happening, we can pick up the 3 or 4 that really are good and scale them up in the whole country? Because India is not a collection of states. India is a nation. So if something is good done in Gujarat, why is it not available to the rest of the country? If something is good is done in Madhya Pradesh, why is it not available to the rest of the country? Why Madhya Pradesh has to go through all those mistakes that Gujarat made in developing their program so that they can say, oh, this is done in Madhya Pradesh? The problem with that is, when you generate data out of all these different tools that don't speak to each other, you cannot actually create big data. And at the national level, you don't get a good picture of what's happening everywhere, because most of this data is not talking to each other. So where is that data? So then every time you have to do something, you have to do a special survey to get special information. That's such a waste of time and energy. I'll stop here. Otherwise, I might be thrown out of here. But listen, I mean, as the minister said, Honorable Minister said, when India does it, it has an impact on world statistics. And there's a place for Gujarat in India, and there's a place for India in the world, and there's a major place for India in South-South collaboration. Your M Mamta, E Mamta, and Kilkari, I can think of 50 countries that will today take it and deploy it, and it will make a difference all over the world. So collaboration, open source, let's work together. Thank you very much.
Thank you, sir. Between Mr. Arsenal and Mr. Sharad Sapra, they have found, given us food for thought on one is generating evidence, and Dr. Sharad Sapra has very infectiously excited on the options which we are using of technology and creating evidence-based decision making.